Marnie Nabudni, and welcome everyone to Grand Round for this week. I'd like to acknowledge that we meet today on the lands of the Kaurna people and pay my respects to their elders, past, present and emerging. I extend that respect to any Aboriginal and Torres Strait Islander peoples present today. Welcome to those in the room, a small dedicated crowd, and welcome to those of you online as well. It's my pleasure to be joined today by Dr. Jennifer Phan. She is a trainee at SA Pathology and comes to talk to us about the very important topic and very clinically applicable topic of genetic testing in practice, when and how to order. Thank you so much, Jennifer. I'll just get your slides up. There it is. Oh, I actually did. Yeah.
Perfect. Well, thank you so much for the introduction and thank you so much for having me here today. So pretty much exactly as we said, why are we here? Why do you need to listen to this talk? So genetic testing is becoming a lot more prevalent and relevant in everyday medical practice. I won't sing for you today, but it is becoming a lot more accessible. There's new technology being developed all the time, new genotype, phenotype discoveries in the literature, new drugs being developed for precision medicine, and there's new Medicare items being introduced every year. So it's really important that you now know when and how to order. So a brief outline of the talk today, we'll start off with a bit of an introduction, a refresher about genetic concepts, and then an overview of all the different genetic testing techniques. And then we'll go into the details about how to actually order genetic testing, why, what, how, and all of that kind of thing. Basically, all the information you need to know to not send me something like this, which we actually received in the lab last week. So it is a real request. Yes, that was not quite our reaction though. So starting off with a bit of a refresher back to basics. So our genome is made up of base pairs A, G, T, and C, and those base pairs together make up genes. All of those genes are packaged up together in chromosomes. We have 46 chromosomes, and that makes up our genome overall. With genes, we've got coding regions, exons, and then non-coding regions, which is basically everything else that's not coding for a protein. We've got different types of mutations, aka genetic variants. So starting off very small, we've got single nucleotide changes, so a change from an A to a G, for example, or small insertions or deletions where that's basically a small insertion or deletion of a couple of nucleotides. Then we've got repeat expansion disorders where we've got a repeating motif that's repeating over and over and over again. And once that motif expands up to a certain threshold, it becomes pathogenic. I'll just plug SA Pathology here and our clinical director, Dr. Sui Yu, who's my supervisor. She actually discovered the molecular mechanism of Fragile X as part of her PhD. So then moving on to larger types of genetic variation, we've got copy number changes. So that could be whole exon deletion or duplications, whole gene deletions or duplications, or whole chunks of the chromosome actually being deleted or duplicated. Then we've got structural changes, and we don't have actually too much loss of genetic material with those, but it's just been reorientated in some way. So one part's been inserted into another chromosome, a part of the chromosome split, so inverted, or perhaps two chromosomes have done a bit of a swapsie, so translocation. Then getting even larger, we've got aneuploidy, and that's a change in the actual chromosome number. So with trisomy, we've got a whole bonus extra chromosome. With monosome, we've got loss of a chromosome. Then talking about different inheritance types, so we've got autosomal dominant, so remembering we've got two chromosomes, we get one from mum, one from dad, and so we've got two copies of each gene. With autosomal dominant, if one of those copies is faulty, it's got a pathogenic mutation, then you'll end up developing disease. Whereas with autosomal recessive, you need to have two hits, so both those copies of that gene have to have a pathogenic mutation to end up developing disease. X-linked is similar but special in that males only have one X chromosome, whereas females have got two. So unfortunately for males, if your one copy of your X-linked gene has got a pathogenic mutation, you'll get disease. Whereas females, we've got a backup copy, so it's a little bit different. just want to quickly talk about the difference between germline and somatic mutations. So with germline mutations, they can be inherited from either one of your parents, and they're basically, that particular mutation is present in every single cell in your body, and you can pass it on to your children through your gonads because your gametes are also carrying that same mutation. Whereas somatic mutations, sort of acquired mutations, they're not something you're born with. At some point throughout your life, cells are dividing all of the time. One of those cells makes a little spelling mistake, and then you end up with a mutation. And then all of the cells that are derived from that particular cell will have that same mutation. It's not heritable, so you can't pass it on to your children because it's just located to that group of cells derived from that original cell with the mutation. This concept is quite common in cancer. So within cancer, that particular cancer, it's got those cells are the one that have that somatic mutation. We won't talk too much about somatic mutation today because it's very complex and very involved, but maybe I'll do a rerun for next year. So I just want to do a bit of comparison between radiology and genetic testing. So I think everyone is very familiar with all the different modalities with radiology and how we use different modalities to find different, different types of disease. So if you're looking for a community-acquired pneumonia, you're probably going to go for a chest X-ray. If you're looking for a PE, you're going to go for a CTPA. Hemorrhagic stroke, you're going to go for a CT brain without contrast. It's a similar concept with genetic testing. Depending what kind of genetic variant you're looking for, you're going to use a different technique. So just talking about the different types of genetic techniques, we can sort of divide them into two categories. So we've got cytogenetic techniques, which are looking at the structural chromosomal level view. And so that includes techniques as a karyotype, microarray, and FISH, so fluorescent in situ hybridization. Then we've got molecular techniques, and they're looking at variants at the nucleotide level. So we've got single variant testing, single gene testing, multiple gene testing, so a gene panel, and then we can look at absolutely everything, so whole exome sequencing or whole genome sequencing. So we'll just start off with this analogy I came up with, the genome as a library. So if we think of all the nucleotides as the letters in a book, all of those letters strung together, they make up a gene or a book. And so all of those books or genes, they're shelved on bookshelves. And so you can think of a whole row or bookshelf as a chromosome. All those chromosomes or bookshelves all together, they make up a library, so your genome. And just like a library, we have a catalog. So we know how many genes they're supposed to be, where they're supposed to be shelved, and where they're supposed to be located. Going back to cytogenetics at that chromosome level, starting with the karyotype. So that is kind of like being in a drone and having a bird's eye view looking down at the library. So you can see physically with your eyes large changes. You could be like, oh, wait, there's an extra bookshelf 21. So that's trisomy 21. You'd be like, oh, wait, we're missing a whole chromosome. That's monosomy. And so you can also see large chunks. Oh, part of that bookshelf's deleted, part of that bookshelf's duplicated. So these are the things that we can see with the karyotype. We can't use the drone to fly down and look in between the bookshelves. It's only what we can see from a high up level view. So it's not a very high resolution technique. A microarray is where we're getting that finer resolution. We're getting to either that single gene level or sort of multi-gene level with a microarray. But the difference with a microarray was not walking along the library looking at all the bookshelves. It's more of an electronic stock take of all of the genes in the library. So we're just checking, we're doing electronic stock take. Have we got all the genes we're supposed to have? Do we have the right number of them? Then lastly, FISH, that is a very targeted technique. So what we're doing with FISH is we're just looking at a single book or like a combination of books or fusion of books, and we're just checking, hey, is that book or fusion of books in the library? Yes, no, how many of them do we have? Depending on the type of FISH technique, we can also get a little bit of locational information as about, hey, is that book actually shelved on the right chromosome or not? Now, the important thing to think about with cytogenetics is we're not reading any of the books. We're not opening them up. We have absolutely no idea what's inside. It's just about, is it there in the right number? And depending on the technique, is it there in the right location and the right orientation? Now, moving on to molecular testing, that is when we are opening up the books and we're reading to see what's inside. So with single variant testing, we're getting that BRCA1 book. We're opening up to say, page 5, paragraph 3, sentence 2, word 1. Is that word spelled correctly or not? Yes, no. Then we close the book. Don't look at anything else that's happening on the page. Excuse me, similar kind of concept for common variant testing. That's where we're testing multiple variants, like a hotspot panel. We're opening up the BRCA1 book to say page 5, 20, 70, 30. We're looking at that specific word on the page. Is that word spelled correctly? Yes, no, closing the book. Then moving on to single gene testing. So that's where we're getting the BRCA1 book and we're actually reading all the way from start to end. Any spelling mistakes, any chunks of it missing or not. Similar kind of thing with the gene panel. So what we're doing, taking all of the books off the bookshelf, in this case, that are related to breast ovarian cancer. So all of those books that are related to that topic, we're reading all of those books from start to end. Any spelling mistakes, anything that's missing from those books. And then whole exome or whole genome sequencing, that is where we're looking at every single book in the library, reading every single book from start to end. And so you can see on a comparison point of view, the difference between single variant testing from whole exome to whole genome sequencing. On one end, it's very targeted, it's very cheap, it's fast, it's quick. Whereas with whole exome, whole genome seeking, it's very expensive, it's very slow, because it takes a lot of time to read all of those books and check the spelling mistakes. And so there's a bit of a trade-off. So with the single variant testing, very targeted, very fast, low risk of having incidental findings, very unlikely to find any variants of uncertain significance, but because it's so targeted, there's that risk of missing the diagnosis. Whereas on the other end of things, because you're looking at literally everything, very high risk of incidental findings, very high risk of finding variants of uncertain significance. All right, so we want to order a genetic test. So there's a lot of things to think about when ordering genetic testing. Why do you think this patient needs genetic testing? Which test should you be ordering? What do you need to think about or do before ordering? How are you actually going to order the testing? What sample do you need? What are you going to write in the request form? And then what do the results mean for the patient? And then along the way, who are you going to call for help? So in terms of indications for genetic testing, there's quite a few. So we've got diagnostic, confirmation, predictive, carrier, and segregation. Then there's a bunch of other sort of really subspecialized indications, which we won't talk about today. So prenatal population screening and so on and so forth, but we'll save those for another time. So why does indication matter? Always matters, just like when you're getting a consult. The question is, what's the clinical question? So it's the same thing with genetic testing. Why are you ordering the test? Is it an appropriate test request? Why are you ordering the test? And how is that information actually going to change patient management? And then what technique is going to be used? As we were talking about earlier, is that requested test, is that the best way to get the information that you want? Are we trying to go for targeted testing or are we doing untargeted testing? Do we know what we're actually looking for? And then the indication changes a few other things. It changes who can actually order the test, what kind of consent and pre-test counseling requirements are involved, what sample requirements, and then of course the test cost. Who is going to pay for this testing? Is it actually covered by Medicare? So talking about what technique to order, we need to go back and think about what's the mutational mechanism of the disease. So with Klinefelter's, that's antibody XXY. The best bang for your buck for that is a carrier type. With Huntington's disease, that is a repeat expansion. We're not going to be able to see that on a carrier type because we're not opening up the Huntington's gene to read the book. So for that, you need to order repeat expansion testing in the Huntington's gene. And then going on to think single gene panel, what should we do? So generally only really recommend single gene testing for diseases that have got a really strong specific phenotype. So a good example of that would be alpha thalassemia, which technically we test for 2 genes, but they're basically the same copy of the same thing. But otherwise, the majority of genetic conditions are genetically heterogeneous. And so more than one gene can cause a same or a similar phenotype. So to get best bang for your buck, to not miss the diagnosis, we recommend doing a gene panel for those. Now, in terms of consent requirements, genetic testing is a little bit different to other normal pathology testing. It's got some unique ethical implications. The most important thing is with genetic testing, the result doesn't just affect the patient in front of you, it can affect their parents, their children, those future children, all of their other family members. That result means something for other people. There's also some insurance implications involved with genetic testing that changed recently in the last year or so. I won't go into that, but if you want to contact the Adult Clinical Genetics Unit, they've got some great information packs. One is sitting right, well, not the information pack, but she's an information pack is sitting right in front of me. And then, of course, with genetic testing, just like with radiology, we can have incidental findings. So an example we had earlier this year, we actually found a BRCA2 gene deletion on a microarray that was ordered in a child with intellectual disability. Totally unrelated to the reason for testing, but a very significant and clinically actionable finding. Also potentially has a lot of implications if it was inherited from one of his parents. Then with genetic testing, as we euphemistically say, it can discover unexpected family relationships, aka dad is not dead. So always important to discuss that. And with any kind of other testing that you do, the results may be inconclusive. Now, for some of our indications for genetic testing, prenatal, predictive, so on, because the complexity of that testing is so advanced and the implications of that testing is so profound that we require formal, professional pre-test genetic counselling and written consent. Otherwise, for other genetic testing, we do recommend getting written consent as a way to sort of remind yourself to talk about all of these unique ethical implications. Kind of like the surgical safety checklist, it's just going through all the motions, making sure that the patient understands what they're in for. So this is an example of our consent form, and so it's got all of those things that we just talked about: unexpected family relationships, incidental findings, and so on. Now, in terms of ordering genetic testing, most pathology that you order day to day is relatively cheap. We are extremely expensive. We are hundreds, if not thousands of dollars. And so it's really important to know about this when you're ordering, especially if you order it and your consultant says, why'd you order this $2,000 test? But also very important to know for the patient, are they going to get hit with a $2,000 bill? So speaking a little bit more of that. So while we're getting new Medicare items every day, unfortunately, the majority of genetic tests are not covered by Medicare. If they are, there's super strict criteria. It's a diagnostic criteria, who's allowed to order the test, and if there's been there's a family history of genetic testing. So it's very important to check who is going to pay for the testing. So if they're a public hospital inpatient, it's covered by hospital funding, activity-based funding. If they're an outpatient, it's covered again by the hospital, but it will be charged to your department. If it's a private patient, Medicare eligible, then we'll bulk bill to Medicare. Obviously, only if they have Medicare. Otherwise, the patient must pay. And it is your job, please, as the requesting doctors, to get that financial consent, to talk about, guess what, this test is going to cost $2,000. Are you able to pay? These are the options if you can pay, these are the options if you can't pay. You know, what's the implications if you do or don't get the test? So it's important to have that conversation before you send them off to get their blood taken. If they're happy to go ahead, please send us a completed agreement to pay form along with all of the paperwork. That's what our agreement to pay form looks like. There's the link, take snapshots of that. All right, so let's start talking about the indications for genetic testing. We'll start with diagnostic. So very similar to any other kind of diagnostic testing. The patient's got a phenotype, they're affected. They've got some kind of signs or symptoms and you're like, oh, I reckon this is genetic. And so in this case, the patient is the proband. No one else in the family has had genetic testing or a genetic diagnosis before. So very similar based on this clinical picture and the patient in front of me. I'm thinking that I want to order this genetic test to exclude or confirm this genetic diagnosis. So I've listed quite a lot of indications for genetic diagnostic testing by specialty. This is by no means exhaustive, but I just want to give you a bit of a flavor about what kind of indications you may think about for genetic testing. Then you can also see there, depending on the indication, we're ordering different test techniques. So for example, with hereditary thrombophilia, you're probably going to do the thrombophilia screen first with protein C, protein S, but also the factor V laden common mutation and the prothrombin common mutation. That all comes back normal, but you're thinking, oh, this patient is clotting a crap ton. That doesn't make a lot of sense. Then you may be thinking about reflexing to do a thrombophilia gene panel. And a few more indications. A lot of these ones on this particular slide, you'll be ordering gene panels because they're very genetically heterogeneous. One particular example I want to point out is, as we were talking about before, repeat expansion. So a lot of neurodegenerative diseases tend to be caused by repeat expansion. So say, for example, spinocerebellar ataxia, it's best to order a spinocerebellar ataxia repeat expansion panel first. If that's normal, then you can think about reflexing to an ataxia gene panel. So in terms of actually ordering this, Anyone can really order this, but we do recommend that the majority should be ordered by a non-GP specialist, just due to the specialized nature of the disease and the complexity of the results. Only clinical genetics is allowed to order a whole exome or a whole genome, just due to the extreme complexity and complicatedness of that testing and the results. As we were speaking about before, we do recommend getting written consent just as part of good standard medical practice. In terms of results, similar in one way to other pathology, either we don't find anything, but we can get different types of variants. So we can get benign, likely benign, variant of uncertain significance, and then likely pathogenic or pathogenic. And you can see the difference in terms of clinical utility with those results. We'll go into a little bit more detail about what those mean later on. Okay, so you found a likely pathogenic or pathogenic variant in your proband, in your patient. As we were talking about before, it's so important that we then go on and do cascade testing to all the other family members, because they also need to know, do they also have that likely pathogenic or pathogenic variant? It's important that you need to think about all of the other family members that are connected to that patient to do confirmation, predictive, or carrier testing. Now, with known familial variant testing, so we found that variant in another family member, we will only test for that known familial variant. We're only going to open up the BRCA1 book to page 5 and just check for that word, nothing else. So that means that if there are any other variants in that gene of interest, we're not going to find them. The only exception to that is if we have a common variant panel, such as for cystic fibrosis that we do frequently, we will just test all of those at once, because that's the way our assay is set up. Why aren't we testing the whole gene? As we talked about before, it's cheaper, it's faster, and it's not clinically indicated. Just like if someone has a fallen outstretched hand, you're just going to do an X-ray of the arm. You're not going to, if that comes back normal, you're not going to be like, oh, let's just check for fractures in the rest of the body. No, because that's not the reason why they're presented for testing. Now, the cost for this is about $400, depending on the technique that's used. Some cases are covered by Medicare, but again, always good to double check. So this example of what not to do, sadness. There's not a lot of information on this form, and us in the lab are like, well, what the frick do you actually want? So let's talk about how to not do this. So with known familial variant testing, you need to tell us what you want us to test and where to look for it. So that example just before, Loeys-Dietz syndrome, that's an autosomal dominant connective tissue disorder. It's got about 5 genes associated with it. So that's like saying to us, hey, there might be a spelling mistake in 5 of these books. We don't know where or what, but have fun. So please give us that information. So with sequence variants, we need to know the gene. We need to know what the sequence change is, and we need to know what the ref-seq transcript is, which we'll talk about shortly. With copy number variants, we need to know the chromosome number and the band. So here, chromosome 22 on Q arm, band 11.2. With exons, we need to know which ones were deleted or duplicated. And that's just a little snapshot of one of our reports. Down the bottom, I've highlighted the information that we need to do known familial variant testing. So the reference sequence is kind of like the addition of the gene. So we need to know that gene addition to know we're looking in the right spot. I'm sure everyone's very familiar or would like to not be familiar with Talley and O'Connor, but the general content of it is probably about the same, but it has changed a little bit over time. So what's on page 10 of the 4th edition of Talley and O'Connor is very different to probably what's on page 10 of the 9th edition. Now there's 2 volumes of Talley and O'Connor, I can't believe it. So this is an example we had last year. So in the APP gene, the proband was tested in 1999, and the gene addition at the time, the sequence variant was 1852. We tested another family member in 2021, and using the latest gene addition, the sequence variant was actually 2077. So that's why you really need to know that gene addition, the ref-seq transcript. So we know we're looking in the right spot, because for this, it was the same gene, the same variant, but it used different nomenclature. The other thing we like to know is we like to know the proband details. And the reason for that is we like to get a little sample of the proband's DNA or another family member's DNA who also has the variant. We like to use it as a positive control for our testing, because we want to make sure that we're actually looking at the right part of the gene to detect the variant. Don't want this situation up here where we're looking up there and the variant's actually down the bottom. And so it's very important that you give us that information about who the proband is and where they were tested, so then we can go on and get a DNA sample to use as a positive control. So It is your job, please, as the requesting doctor, to give us all of this information about known familial variant testing. So if they were tested at SA pathology, super easy. All you need to do is give us that report accession number. That's located at the top of all of our reports. I've highlighted it there. Starts with GM, bunch of numbers after it. Otherwise, you can give us the proband name and date of birth, and we can figure it out ourselves. If they were tested somewhere else, so not SA pathology, the easiest thing is to give us a copy of that original report. We cannot test without this information. So if you can't get it, the patient doesn't know it, then we recommend referring to clinical genetics, because they are the absolute masters at ferreting this type of information out. Right, so let's start talking about different types of cascade testing. So with confirmation testing, a similar kind of scenario, the patient in front of you is affected and you're thinking, hey, do they have the same genetic diagnosis as this other family member? Anyone can really order this test. We do recommend in conjunction with a specialist referral, if it is a GP who's ordering it, plus or minus in consultation with genetics, and similar sort of standard consent counselling requirements. With predictive testing, this is a special scenario. So that's for autosomal or X-linked dominant diseases that have got a delayed age of onset. So prime examples would be familial cancer or neurodegenerative disorders. So this is a bit different in that the patient in front of you is completely unaffected. There's no signs or symptoms of disease. And so the question here is this patient in front of me going to develop, or are they at increased risk of developing this disease? Do they need to have some kind of increased surveillance? Do they need to have risk reducing or pre-symptomatic management? So for this particular test, we prefer that these come through clinical genetics only because of the extensive pre-test counselling and consent requirements before the testing. The other thing that we have for predictive testing is we like to have 2 independently collected samples. So what does that mean? We have venipuncture, we get the sample, then we wait 15 minutes, then we venipuncture again and get a second sample. Or it's been collected by 2 different collectors. And why do we want to know that? Is because there's no other signs in front of us that the patient has got a disease. Sample mismatches happen. So if we're going to give someone a diagnosis, we want to be sure that it's for the right patient and the right result before they go off and have life-altering surgery. Then lastly, we've got carrier testing. And so that's for autosomal and X-linked recessive diseases. And they're similar again, they're unaffected, but the difference here is that they will not go on and develop disease because they're just carrying the pathogenic mutation. So the whole point here is, what is the risk of having an affected child? How will these results affect this patient's reproductive decisions? So again, anyone can pretty much order this test plus or minus in conjunction with clinical genetics and standard consent counselling requirements. Then the last category of cascade testing is segregation testing, and that's only for variants of uncertain significance where we've identified that VUS in a proband. So the patient could be affected or unaffected, and the whole point of segregation testing is, will testing of other family members help reclassify this VUS? Will this information give us enough data or evidence to be able to upgrade it to likely pathogenic, or downgrade it to likely benign or benign? So an example is we've got this VUS in one affected family member. Say we go on and test 5 other affected family members. They've all got the same variant. We're thinking, oh, that's looking pretty suspicious. But if only one family member's got it, no one else has got it, we're a bit like, that's probably not the variant that's causing the phenotype in this family. So because this test is a bit complicated, we do recommend that it's only ordered in conjunction with a referral to clinical genetics, and also only if we, the lab, have recommended it. Because not all VUSs are able to be reclassified with segregation testing. It's a lot of time and effort, and I guess difficult for patient expectations if they do this testing thinking, oh yeah, we're going to reclassify the variant, but then actually it would not end up that way. So we do recommend referral to clinical genetics for that. So we've got a bit of a flow chart sort of going through all of the different pathways and options. And so always be thinking about, if we've got a pathogenic variant, then we need to cascade in other family members. If those family members are not under your care, then please refer them to clinical genetics so then they can do all of the contacting, the letters to contact those other family members and recommend that they get testing. so we've talked about all of these things. Now it's time to order. How do we actually order genetic testing? So what information do we need to put on the request form? Please give me the phenotype. Please give me information about what kind of signs and symptoms the patient actually has. If there's Medicare criteria, please put them down as well. And then what are you actually ordering? What's the test request? Is it diagnostic? Is it predictive? Is it carrier? And what kind of technique do you want us to use? Don't be like that other doctor and write DNA testing. That is basically like writing radiology. It's completely unhelpful to us. We need to know what technique do you actually want us to use. If you want us to do FISH, what probe do you want us to use? Don't just write X-ray and X-ray of what? The arm, the leg, FISH. Which part of the genome do you want us to actually probe? And then, is there a known familial variant? So if there is and you want us to look for that, please give us the requisite information that we need to go and test for that known familial variant. It's great if you pop your name and pager on there, so if there is any problems, I can call and discuss. And then if you are ordering on behalf of a consultant or another specialty, please include that consultant's name. And then definitely, if you have discussed with clinical genetics, please pop that down on the form as well. And then any other forms as required. So either a signed consent form, or you can write written consent obtained on the request form. And then if it is a private patient, please include that completed agreement to pay form with all the other paperwork. So let's go back to that example before. So it turns out this particular patient was unaffected, and so therefore it was predictive testing for this TGF-BR1 known familial variant. The brother of that proband who was tested through assay pathology. This type of testing is not covered by Medicare. Because it's predictive testing, we recommended that this patient was referred to clinical genetics for that pre-test counselling and consent. So I want to talk about NGS testing because I think that is the majority of what RA clinicians will order. So with assay pathology, the majority of our whole gene sequencing is performed by next generation sequencing, and we do the exons only. Or as with any kind of testing, there's always limitations. We always pop them in the teeny tiny fine print down the bottom, but to just mention, can't repeat those repeat expansions. We can't look at structural rearrangements with NGS, and we don't see any variants in non-coding regions because we're just looking at exons. If it's a genetically complex region, we have a bit of trouble with NGS in those areas as well, and we will say which genes we have trouble with if that's the case. In terms of the different platforms that we have, oh, that formatted weird. Anyway, in terms of the different platforms that we have at assay pathology, we've got 3 different platforms for NGS. The first one is our heme panel that's been designed in-house, and that's been specifically designed to look for somatic variants in hematological malignancies. Then we've got our GMP Focus platform, which we also developed in-house, and that's a specific list of genes that we tend to get a lot of frequent orders for and don't usually require reflexing to any other kind of testing. And because we designed it in-house, we've added extra probes and everything to get better coverage of the genes to look for any variants that might be there. With the exome platform, that has been bought off the shelf from a company that covers all the coding regions, the exons of all the genes. And because we're looking at absolutely everything for that particular platform, we can do reanalysis of exome data. GMP Focus, what's that? Oh, so GMP stands for genetics and molecular pathology. That's our area. And I guess it's focus because we've focused on a specific bunch of genes that we think deserve to be on that platform. That's why it's called GMP Focus, I guess. And then lastly, we are currently in the moment of validating and creating whole genome sequencing. So that's coming soon, but remember, only for clinical genetics. And with all of our platforms, what we actually do is we sequence all of the genes that are included in that kit. But then what we do is that we mask the data analysis to just the genes that you have requested. So then there's no risk of incidental findings. So that's why with the exome platform, say you've done an ataxia gene panel, we didn't find anything there, but then you're thinking, I think something is really going on with this patient, then we can go back to the exome data and reanalyze it for another gene panel, or just completely open it up with whole exome in conjunction with clinical genetics. So we're ordering an NGS test. Please tell me what gene or gene panel you'd like. So now we're moving towards using our gene panels from Panel App Australia or Panel App UK. You can look that up yourself on the internet, and they're crowdsourced, curated gene panels that have that a bunch of experts have gone together and thought, yeah, I think this gene needs to be on this panel. And so you can combine more than one panel from the Panel App or Panel App UK. So say if you want to do the dystonia super panel plus the ataxia super panel, very easily done. We only do the green and orange genes from those gene panel lists because those are the ones that have got evidence for them. Requests for custom gene panels, we tend to restrict those to clinical genetics just due to the complexity. So unfortunately, in terms of ordering, the system is a bit clunky and outdated. We're working on it, but things take time. So most of our tests don't have a named orderable. So there's actually no option to order them on Sunrise. I do apologize. So in terms of the options for ordering, you can do the old-fashioned way and do a handwritten form, or you can do electronic ordering on Sunrise using the genetic testing GMP. So genetics and molecular pathology, you can use that orderable. But then please write in the notes what test you actually want. So this particular example, they did genetic testing GMP and they just wrote pyoderma gangrenosum. Did they want HLA-B27? Did they want some kind of dermatology panel? What did they want? Turns out that they wanted the NGS heme panel. So please put that information on there. So in terms, again, because we don't have these specific orderables, there's not a lot of great visibility in terms of has the lab actually received this request, because we order them under a laboratory specific orderable that unfortunately is not available or not visible on Oasis or Sunrise until a report has issued. So it's quite annoying. There's no way for you guys as the requesting clinicians to know if we've received a sample or test request. So we're using the specimen received orderable as a bit of a workaround to try and increase that visibility for you guys. And so that specimen received, it shows up under the Oasis view in tab in Sunrise, and there's a little comment there that says what test was actually ordered. Once the report's been issued, it will pop up as something like generic sequence analysis report or something similar to that, and that report will correspond to the date the sample was collected, not the date the report was issued. In terms of sample requirements, for germline testing, we generally prefer blood, and we like our very own tube to minimize the risk of contamination, kind of like a group and hold. For most genetic testing, an ETTA or a purple top, it's good to go. For carrier type of fish, we prefer a lithium hep, so a green top. We can do buccal swabs for those people who are a bit needle-phobic, difficult bleed and so on, but we can't use them for all techniques because the DNA quality and quantity isn't enough with a buccal swab. So if you do want to do that, then you need to use the special Origin saliva swab for microarray or NGS. We don't have them available in pathology collection centres because they're a bit expensive, so you need to call us to send one out to you to collect for your patient. Then there's a few other sample types we can use for specific testing situations. Contact the lab for collection requirements if you need to. I just want to talk about a karyotype. So the whole point of a karyotype is that we're looking at those chromosomes during mitosis when the cells are dividing. So for cells to divide, sample has to be alive. There has to be some cells that are alive. So then we can see those cells in metaphase when they're most chunkiest. So if you send me a sample that's in formalin or dry ice, the sample is dead. We cannot do anything with that. So if you want a karyotype, please don't do that. Right, so in terms of the genetic testing process, it's still quite a manual and laborious technology. There's not too much automation that we have in the lab in terms of laboratory steps, and then some of those steps can take hours, overnight, or even days. So our NGS wet work setup, it takes a full week. And with the data analysis and interpretation, that's still generally a manual process. We go through and check them all. It's a little bit of automation, but still there's quite a lot of manual curation. As we were talking about before, the larger the gene panel, the more genes, the more spelling mistakes that we have to check. Okay, so we've done all of that. Now we've got the report. What do those results mean for the patient? So as we were just saying, we've gone through, we've checked for all of these spelling mistakes. And then just like in real life, you're writing a journal article, you do spell check. You don't say accept all and then send that bad boy off to nature. No, you go through every single spelling mistake and make sure, is that actually a real spelling mistake or has Word just gotten a bit too feisty? So similar thing for us. We go through all of the variants and we curate them to make sure, is this actually a disease-causing variant or is it benign? And the whole point of variant curation is, how does this variant affect normal protein function? Is it going to do something bad or is it going to have no effect? And so one of the first things that we do is we check, is this variant in a gene that's a good phenotype match? That's why it's so important for you guys to give us that phenotype information so we can use it as part of our variant curation. And then there's a lot of other data that we use to figure out, is this a pathogenic causing variant or is it benign? So we use a lot of databases out there. We look at the literature. We use sort of predictive computational tools. It's quite an involved process. So just coming back to the end with that scale, so you can see based on the evidence that we've used for variant curation, we can either go, yep, it's likely pathogenic or pathogenic. We are 90% or plus certain, yep, this is a bad variant, it causes disease. Whereas on the other end of the scale with likely benign or benign, we're thinking, yep, we've got enough evidence that we are 90% plus sure that this variant, don't worry about it. But then unfortunately, there's this massive gap in the middle. So, you know, from 10 to, can I do maths? Yes, from 10 to 90%, where it's classified as a variant of uncertain significance. We just don't have enough information or evidence or data to say, yep, definitely it causes disease. No, we're not really sure. And it's quite frustrating for us as a laboratory, you guys as clinicians, and for patients to get these VUSs, but with time, VUSs can be reclassified. So it's always important to think about referring to clinical genetics and think, let's have another look at this in maybe 5 years. Maybe there's more evidence out there to say, yeah, this VUS is pathogenic or no, it's benign. Now with our turnaround times for genetic testing, don't call us up and say we need this by tomorrow. Can't happen. The only one we can do that for is fish. Everything else is days to weeks to months. Even if it's urgent, days to weeks, because of the wet work process and the amount of work involved with variant curation. And so because of that, because of the long lead time between testing and then the results, it's always important to remember to book that follow-up appointment with your patient to review the results and then to discuss them. And then I just want to list out a few genetic testing things that we have that we currently don't have at SA Pathology. So with mitochondrial DNA, we currently send that away to VCGS in Victoria. Somatic cancer panels, we currently don't have them in-house, but we are developing them any day now. Pharmacogenetics, we tend to send that away for private pathology. The exception is DPYD. We've just introduced that this year at SA Pathology. Then preconception carrier screening, or NIPS, we send that away to private pathology. And there's a few genes that are quite complex. It's a bit too much effort for us to do them in-house, so we send them away to other labs who have got specialties. All right, so you've gone through this entire process, or anywhere along the way, you want to know who can you call for help. So I just want to point out with genetic pathology and clinical genetics, I'm a genetic pathology registrar, I'm through RCPA. I don't speak or talk to patients anymore, whereas clinical genetics, that's through RACP, they're through physician training. So if you want someone to speak to your patient, clinical genetics is the way to go. So with clinical genetics in South Australia, there's 3 different branches. We've got the Pediatric and Reproductive Genetics Unit, that's based at WCH. There's an on-call pager there. We've got the Metabolic Unit at WCH at RA, and there is also a 24/7 on-call metabolic doctor if there's anything that you need to discuss with them about. And then we've got the Adult Genetics Unit at RA. We've got our number there. And of course, at any time, you can refer or consult with genetics with anything that you have any queries about. So test selection, you want some advice on how to do consent, or you want them to come out and do a bit of a session with your unit about counselling. They've got information packs. They've got all the stuff that you need. And then with us, so GMP, genetics and molecular pathology, we've got 4 different labs at SA Pathology, and they've each got their own area of expertise. We don't do the same tests across the lab just because it's very expensive to duplicate. So we've got a lab down at FMC, 1 lab at Frome Road, and then 2 labs at WCH, each with their area of expertise. And so you can probably best bet is to call our DNA extraction lab at that number, and they can help direct your call to the right lab about the testing that you want to know about. Oh, I ended a little bit faster than I thought. So that's everything. I really appreciate you guys coming to listen and learn about how to not do DNA testing.
Thank you so much. That was really fabulous. You've got a lot of people online. So if people online would want to ask questions, please feel free to turn your video on so we can see you or ask in the chat. So I fear I may have been one of your terrible orderers in the past. I'm really starting to cringe. It is a matter of not knowing what we want and not realising how big the library is. But say if I did have, someone whose brother had been found as having Loeys-Dietz, if I put Loeys-Dietz 4 on the form, would that be better than just putting Loeys-Dietz? I mean,
mildly better.
Mildly better.
But even better would be if you could write that brother's report number on there and then.
I guess that brings me to the point that one of the most difficult things is families often report that a relative has a condition, but they know so little about it and they cannot point you to the resource. So do we need to refer these people into clinical genetics? That's the message you've given. Will this avalanche of referrals be coming next week?
Hopefully Erin won't be angry with me.
Yeah.
But I would say yes, because they've got genetic counsellors who are really good at finding out that information and calling up patients, and then it turns out no one actually had genetic testing, or perhaps someone had testing overseas. They can get that information. They're really good at ferreting that information out. The patient. Oh, Erin can come on and discuss.
Please come on.
I was going to say, you don't necessarily have to refer them all to clinical genetics, but you can just give us a call. And we have a statewide genetics database. So anyone who's been tested in the public sector in South Australia will be in our database. And we collect pedigree information. So when someone's tested, we collect their entire family history, all the names, all the dates of birth, and all the dates of death. So we can go back and look at all the historical results.
Okay.
So for example, if you called about your patient with a brother with Loeys-Dietz, we could put his name into the database and say, oh yes, he pops up, he's in a known family. Here's the proband report. Or we could say, actually, we don't know that family. They haven't had testing in the public sector. And then we know we need to do a bit more research.
That's fantastic. Kate.
Thanks, Jennifer. Kate Lynch, guest from Dallas.
Oh, I feel like I've potentially emailed or had an email from in a good way, not a you've done the wrong thing way.
I just find increasingly I'm requesting genetic tests. I'm often liaising with our clinical genetics colleagues to ask. I have two quick questions, one for a comment, one a practical question. So HFE gene testing.
Oh yeah.
I'm finding it's being done by GPs all the time. Sometimes I think inappropriately because it's so low penetrance and it's so common. And I wondered about your comment on that. And the second question is, you said may or may not be covered by Medicare, but a lot of people finding out whether it's covered, what tests are. So I've just referred someone to ferroportal disease testing. But I'm doing that through clinical genetics, so they can give their expertise.
So I think, so for the first part of your question with HFE, I guess a lot of GPs are ordering it because there is a Medicare item for that HFE common variant, but just that common variant testing, not for the full HFE. So I guess it's not unreasonable to do that as part of first-line testing because it's so cheap and easy to do. But then I guess if there's more concern about if that comes back NAD, then they probably should be referring to you. In terms of trying to figure out what's actually covered by Medicare, I also have a lot of trouble with that. I download the spreadsheet every month to see, oh, have they actually added new items and not told us about it? I think you can sort of err on the side of caution and say, no, this is not covered by Medicare. You can do a quick search of Medicare to see if it comes up, but I would probably err on the side of caution saying, no, it's not covered by Medicare, unfortunately. Did that answer your question?
No, that's good.
Lovely.
So Andrew Somergy has placed in the chat that RCPA and Pharmacology and Pharmacy Societies have received funding from Australia Genomics to establish indications for pharmacogenomic testing in Australia. Thanks.
Yes. So I think it is up and coming. At the moment, we just haven't set up that testing at the moment in the laboratory, but there are certain other labs, particularly private laboratories, that have got specific pharmacogenetic panels that you can order, particularly for, say, the CYP liver enzymes. That's got a lot of evidence for them. It's just that we don't offer them in-house at the moment.
Great. I've certainly been in the position now where, because there is much more genetic testing available, someone has ordered a genetic test on a patient and then the patient has left hospital and it comes back, and there are implications perhaps not for the elderly patient themselves as much as for the family. And I really worry that that consent process you described, which would be done very, very well by the clinical genetics unit, probably hasn't occurred with some ad hoc testing on the ward. Do you think there's much of that to worry about?
I would say definitely yes, and Erin and I have discussed the concerns about that, and so that's why we recommend going back to basics and doing that written consent, because that acts as a trigger to think, hey, actually there's a little bit more to this than ordering just a CBE. These are the dot points that we need to consider.
I would also say, I'm not sure about the SE pathology consent form, but on our adult genetics unit version, there is a spot to put down the nominated next of kin to receive the results in the event that the patient cannot, because that's a big problem. You have an elderly patient who passes away or you lose contact with that patient. So having a documented alternative contact is really important.
Check it out, got that actually. Yeah.
Yeah, in some cases, the patient themselves may not be able to consent because of cognitive impairment, and often that's really not well done. So I think that's an increasing problem. And yet, nevertheless, the information may be very valuable to the family. It's just you don't really, it's very tenuous. You don't have the consent of the patient. So what process do you use? Are the forms that you use in the genetics unit easy enough for other clinicians to use if they get access?
Yes, I mean, it's quite a wordy but straightforward form. And they have been developed at a national level with oversight from the national groups involved in genetic testing so that they are consistent. In sort of commonly ordered, what we call mainstream tests, which is any test that's not ordered by genetics, we have some packs that we've developed that include consent forms with relevant pieces of information. So for example, in the cancer setting, there's mainstreaming packs for ordering BRCA testing, which come with a consent form. But yeah, we have all of those forms and leaflets and patient information sheets available.
Fantastic. I think one of the other things that clinicians probably find is they will order a test and you will look for common variants, but if they've got additional clinical suspicion and none of those turn up, they may be put off by the first report that comes back. When should a clinician pursue further testing, do you think?
Ooh, I guess it all depends on the clinical suspicion kind of thing. So with, say, cystic fibrosis, we've got a common variant panel for that. And then for certain indications, say for newborn screening, we don't end up reflexing to cystic fibrosis because the clinical suspicion isn't really there. But if someone is presenting with classic cystic fibrosis, wet cough, blah, 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 then we would recommend reflexing to full gene sequencing to make sure we haven't missed anything. There's only a few tests that we have common variant screening. The majority are actually gene sequencing. And sometimes we also tend to write that in our reports. If there's high clinical suspicion, then consider doing blah, blah, blah.
I think as a clinician, my worst fear is getting back the variant of uncertain significance report, because I've been really convinced perhaps of some familial tendency for something, and then it all comes to nothing. If I've been going it alone until that stage, should I then refer to clinical genetics for some help?
Yeah, absolutely. So we would say that any patient with a VUS, a variant of uncertain significance, should be referred to us, because sometimes with segregation testing or with collecting other information, we can upgrade or downgrade the variant. And also it's a tricky conversation to have with a patient. We found something, but we're not sure if it's nothing or if it's something. And our genetic counselors are very good at having that conversation. So I think probably all of those patients should see a genetic specialist.
Okay. I've run into some difficulties both with patients with psychiatric comorbidity and whom the variant of uncertain significance is a very difficult thing to talk to them about, but also equally getting them to another appointment can be hard, but it may have profound clinical significance. And the other situation I've found is if families are perhaps estranged and the members are on the other side of the family, it really goes to a dead end with getting other people to test. Do you have ways where families are estranged that you can bridge that?
That's a very difficult question to answer. The South Australian law, I think the wording in the law is to breach confidentiality, there has to be imminent danger. So you have to kind of make a call about what you think imminent danger to a family member potentially is. Generally, we would not break that patient's confidentiality with their genetic result and discuss it with family. But as I said, we have this wonderful South Australian database, and often we have very large families where we will know two people are related and they may not even know they're related. We have sort of, pedigrees that are 50 sheets of paper long.
Yeah.
And so there are situations where we can anonymously risk notify. So if a patient's in our database, we can send them an anonymous letter that just says a genetic condition has been found in your family. If you want more information, please contact us on this number. And so maintain that confidentiality of the proband.
Any further questions? Jennifer, it's been a wonderful talk. Thank you so much. I love the library analogy.
Me too.
You just sort of unpacked it beautifully.